Gastrointestinal bleeding, also called gastrointestinal hemorrhage, is all forms of bleeding in the gastrointestinal tract from the mouth to the rectum. The blood often appears in stool or vomit, but isn't always visible, though it may cause the stool to look black or tarry. The level of bleeding can range from mild, which is, on average, 10% of the whole blood volume, to severe, which is a whopping 30% and can be life-threatening. Symptoms and causes. Gastrointestinal bleeding can be roughly divided into two clinical syndromes: upper GI bleeding and lower GI bleeding. About 2/3 of all GI bleeds are from upper sources and 1/3 from lower ones. Common causes of GI bleeding include infections, cancers, vascular disorders, adverse effects of medications, and blood clotting disorders. Obscure GI bleeding is when the source is unclear following investigation. To start things off, let's talk about upper GI bleeding first. Upper GI bleeding is from a source between the pharynx and the ligament of Treitz. An upper source is characterized by hematemesis, which is vomiting of blood, and melena, tarry stool containing altered blood. About half of cases are due to peptic ulcer disease, gastricoduodenal ulcers, esophageal inflammation, and erosive disease are the next most common causes. In those with liver cirrhosis, 50 to 60% of bleeding is due to esophageal varices. Approximately half of those with peptic ulcers have an H. pylori infection. Other causes include medullary waist tears, cancer, and angiodysplasia. It's worth noting that a number of medications are found to cause upper GI bleed. For example, corticosteroids and anticoagulants. Now, on to lower gastrointestinal bleeding. Lower GI bleeding is typically from the colon, rectum, or anus. Common causes of lower gastrointestinal bleeding include hemorrhoids, cancers, angiodysplasia, Crohn's disease, and aortoenteric fistula. It may be indicated by the passage of fresh red blood rectally, especially in the absence of bloody vomiting. Lower GI bleeding could also lead to melena if the bleeding occurs in the small intestine or proximal colon. Prevention. In those with significant varicosis or cirrhosis, non-selective beta blockers reduce the risk of future bleeding. With a target heart rate of 55 beats per minute, they reduce the absolute risk of bleeding by 10%. Endoscopic band ligation is also an effective way at improving the outcomes, where you just put an elastic band around enlarged vessels so they cannot bleed. Non-selective beta blockers and ABL are recommended as initial preventative measures. Obviously, testing for and treating who are positive for H. pylori is recommended. Transjugular intrahepatic portosemestic shunting may be used to prevent bleeding in people who rebleed despite other measures. There are special diagnostic methods where, if internal bleeding is suspected, diagnostic puncture could be performed. If indicated, X-ray, ultrasound scanning, and computerized tomography can also be used. Endoscopic methods could also include gastroscopy, endoscopy, and others. It will be noted that clinical symptoms and signs as well as the laboratory findings are used to evaluate the severity of blood loss. Treatment. The treatment of hemorrhage must be started with maximum swiftness, since a prompt initiation of therapy can prevent the hemorrhagic shock. The management of severe bleeding has to be started with infusions of blood substitutes before blood grouping and cross-matching. It is important because the human body is tolerant of the plasma loss, and hence a reduction in the circulating blood volume is lower than that of the fall in red blood cell count. Blood transfusion should be considered whenever hemoglobin and hematocrit levels fall as low as 80 grams per liter and 30 respectively. In severe acute bleeding, blood transfusion should be started by the fast flow method through 1, 2, or even 3 veins, while slow infusion can be justifiable only after the systolic blood pressure has at least risen as high as 80 millimeters of mercury. Acid doses is corrected by giving sodium bicarbonate, trisamine, and lactosol. The drugs that increase the vascular tone or vasopressors should be avoided until the volume of circulating blood has been fully restored, since they are likely to aggravate hypoxia. Alternatively, steroids act to enhance myocardial contractility and counteract peripheral vascular spasm. Oxygen therapy should also be considered, especially after bleeding has stopped. Prognosis. Death in those with a GI bleed is more common due to other illnesses, some of which may have contributed to the bleed, such as cancer or cirrhosis, than the bleeding itself. Of those admitted to hospital because of a GI bleed, death occurs in about 7%. Despite treatment, rebleeding occurs in about 7 to 16% of those with upper GI bleeding. In those with esophageal varices, bleeding occurs in about 5 to 15% a year, and they have bled once, there is a higher risk of further bleeding within 6 weeks. Testing and treating H. pylori, if found, can prevent rebleeding in those with peptic ulcers. The benefits versus risks of restoring blood thinners such as aspirin or warfarin and anti-inflammatories need to be carefully considered.